Hello and welcome to Pulmonology Read Aloud once again, this time with the video on bronchiectasis. Today we'll be discussing about the guidelines and some updates on bronchiectasis. Thank you to the subscribers who had asked for this video. So sit back, relax and listen to the updated guidelines on bronchiectasis. Scrolling through the guidelines available on bronchiectasis, the two main guidelines that I came across were both published around 2017. So we haven't had very recent guidelines on bronchiectasis, but these guidelines enumerate such minute details that it's so important to again go back and revise them. The first major guideline was the BTS guideline on bronchiectasis in adults, which is a very huge document of more than 50 pages. There's another guideline which was published by the European Respiratory Society, which is also in the form of question and answers, which also details certain aspects of bronchiectasis treatment. For the purpose of this talk, we'll be talking about the BTS guidelines for bronchiectasis in adults. There are other guidelines that have been also mentioned. The one by the American College of Chest Physicians was published in Chest in 2018 and talked about treated cough in non-CF and CF bronchiectasis. And the other guideline, which is more recent, was published by the ERS in the ERJ in 2021, but it discussed about bronchiectasis in children and adolescents. Just to start, although most of you are pulmonologists here and would know, bronchiectasis is a chronic respiratory condition. We have a syndrome of cough with sputum production and bronchial infections, which is the hallmark of this disease. Radiologically, we notice it when we see abnormal and permanently dilated bronchi. And broadly, for treatment aspects, it has been divided by societies into non-cystic fibrosis and cystic fibrosis bronchiectasis. So bronchiectasis is something that we do keep coming across more often, and especially in this part of the world where I practice. Tuberculosis and post-TB patients develop a lot of bronchiectasis, and it's a common diagnosis in our OPDs. Now, when we look at the treatments around bronchiectasis and the guidelines, there is a concept of what we call as a vicious cycle. So what our understanding of bronchiectasis entails regarding the symptoms and the exacerbation revolves around this concept of vicious cycle. This flowchart is taken from the ERS guideline of 2017, and it beautifully denotes the key components of the disease, which is chronic bronchial infection, so recurrent infections, inflammation, impaired mucociliary clearance, and structural lung disease. So when bronchial infection happens, there's inflammation. This inflammation leads to exudates which are not cleared off because of an impaired clearance, and then it leads to a structural lung disease which will again cause bronchial infection, and the cycle goes on. So when we treat the condition, we would want to treat the chronic infection with antibiotic therapy. We want to suppress the inflammation with anti-inflammatory therapy. We want to improve the clearance or to facilitate removal of the mucus. And we want to take care of the structural lung disease, which is contributing to the morbidity of our patient. Quick revision of what a bronchiectasis suspect is. According to the guidelines, suspect bronchiectasis whenever a patient comes to you with a persistent mucopurulent sputum, and he has certain risk factors, especially in certain disease conditions such as rheumatoid arthritis if they have recurrent infections, COPD patients, and especially those COPDs where you've had a positive sputum culture for Pseudomonas aeruginosa when they were otherwise stable, patients with inflammatory bowel diseases, or any patient with a chronic productive cough. There is a risk population, especially HIV infection, bone marrow and organ transplant patients, immunosuppressant therapy because that again predisposes to more infections. Chronic rhinosinusitis, which forms a huge number of our regular patients that we see, and healthy individuals who may come with a cough or sputum which is lasting more than 8 weeks, and the main symptom should be sputum production. So, under these circumstances, and also amongst asthmatics, amongst COPDs, or asthmatics with severe asthma or poorly controlled asthma, we must rule out bronchiectasis. In fact, for COPD, an investigation of bronchiectasis is appropriate once the patient's sputum cultures are coming positive frequently, or your patient is getting admitted for more than 2 exacerbations in preceding 12 months. So it's really important to have a strong index of suspicion. Amongst the diagnostic testing, the guidelines recommend that all your patients with bronchiectasis should undergo complete blood counts, differential counts for the neutrophil, lymphocyte, eosinophil percentage numbers. In patients where you are suspecting immunoglobulin deficiencies, there is a grade C evidence of checking for serum immunoglobulins IgG, IgA, IgM. Specifically, in our populations with allergic bronchopulmonary aspergillosis, we would want to specifically check for the specific IgE, IgG, IgM also for ABPA, also for SPT, a skin prick test for Aspergillus fumigatus. So, at least a specific IgE and a skin prick test must be done in all patients, especially areas where there is a high incidence of ABPA. And they also mention a specific test called the baseline specific antibody level against Streptococcus pneumoniae capsular polysaccharides. Now, the concept of this test is that if you find out that the levels of the antibody against the polysaccharides of strep pneumoniae is deficient, then you may want to immunize this patient with a 23-valent polysaccharide pneumococcal vaccine. And then you follow it up with another antibody level to see whether the patient has mounted enough response. Now, this test we do not use commonly, routinely in our OPDs, and as we all know that guidelines guide the direction, but sometimes that doesn't reciprocate to clinical practice all the time. So I would encourage you to please write down in the comment box if you are using this test, because as per my experience, we are not using this test too much to find out antibody deficiencies, and we are vaccinating patients, specifically elderly 60 to 65 years of age with risk factors, with the pneumococcal vaccine. But for young adults, this may be a helpful tool. So please write down whether you're using it in the comment box. Other diagnostic testing goes for the etiologies. So if it is cystic fibrosis that you're suspecting, for example, a male with infertility, with malabsorption, early onset disease, you may want to check for cystic fibrosis genetic mutations. For patients with primary ciliary dyskinesia, suspected Carter-Turner syndrome, you would want to do the testing. And otherwise, for all patients, they recommend that sputum cultures should be performed. It's a grade D evidence, but given the scenario of tuberculosis and non-tubercular mycobacterial infection, when you diagnose your patient, we must try to ascertain that there is no underlying TB or NTM infection leading to bronchiectasis. When we talk about diagnosis, high resolution CT scan is very important tool. In fact, it's the most appropriate imaging tool that helps us to understand whether this patient has bronchiectasis. And we use volumetric CTs. We can use dose reduction techniques if we are doing CT more frequently. The ideal CT parameter includes a slice thickness of less than 1 mm and a high spatial frequency reconstruction algorithm. So if we utilize that, we should be able to find the CT features of bronchiectasis. Bronchiectasis on a CT may be sometimes more subtle and mild, like in this image, or it may be florid and very advanced and visible. It is ideally defined as a bronchial dilation, and this bronchial dilation has to be suggested by certain criteria. One of the criteria is the bronchoarterial ratio. So if you look at the bronchus and the adjacent artery, the bronchus is more dilated, so the bronchoarterial ratio becomes more than 1. There should be a lack of tapering of the bronchus as you progress, so it's dilated completely. There should be a visibility of an airway within a centimeter of the costal pleural surface, or even if it is touching the mediastinal pleura, it usually has a distance with it because we are dealing with bronchi here. And certain indirect signs are also helpful, like you may see a thickening of the bronchial wall, you may see mucus impacted, and sometimes on an expiratory scan, you may see air trapping. So these are the common features, and we can suspect bronchiectasis based on them. There are two indices that are mentioned in the guidelines. The first, Bronchiectasis Severity Index, which is a good tool. This tool has several variables, which include the age of the patient, the BMI, the predicted FEV1, hospital admission in the last 2 years, exacerbations in the last 12 months, the MRC breathlessness score, Pseudomonas colonization with other organisms, and radiological severity. So it looks like a very comprehensive and detailed score, and bronchiectasis severity index has been used for most of the studies on bronchiectasis. There's another score that's also available, which is called the FISED score. Now, the problem with the FISED score is, as you can see here, it's less exhaustive, but it does not have the criteria of exacerbation. And we agree that exacerbations are a very important factor in determining the bronchiectasis severity. So at any point of time, a BSI should be a better score. For a quick screening, a FISED score could be used, where FISED would be the FEV1, the age, the colonization, the extent of the disease, and the dyspnea. So FACED, FACED score, it could be a quick score to do on a bronchiectasis patient. Coming to the guideline-based management, a beautiful flowchart has been given. In fact, this guideline has several beautiful flowcharts throughout. So this is a management of stepwise management. The step 1, when you are trying to treat a patient with bronchiectasis, is to treat the underlying cause. So we need to find out the cause. Step 2, before we go to step 2, we have to make sure that we have already educated our patient about airway clearance techniques, and if needed, also enrolled him into rehab in case it's a severe bronchiectasis. Make sure you're vaccinating the patients and you're treating the exacerbations with antibiotics very promptly, and the patient knows what is his self-management plan. Now, if your patient continues to experience symptoms even after doing all of this, then we go on to a step 2. And when we go on to step 2, even if he's not meeting any exacerbation criteria at the time of presentation to you, that he has frequent exacerbations per year, more than 3, then you must add a physiotherapy and a reassessment, and you must start some mucoactive treatment because this patient is having frequent exacerbations. So remember the vicious cycle, we have to break the chain. Now, when this patient continues to be symptomatic, despite giving physiotherapy, despite giving mucoactives, he's still having a lot of exacerbations, we try to identify which organism is involved. If it's Pseudomonas aeruginosa, we need a particular anti-pseudomonal protocol, which we'll be talking about later. If it's other organism, we treat it with targeted antibiotic. And there is a role of a prophylactic antibiotic long-term, which again we'll be talking about in future sections of the presentation. Again, if your patient continues to exacerbate and worsen, he has to be on long-term antibiotics. And if he is still exacerbating with more than 5 exacerbations a year, we consider regular IV antibiotics every 2 to 3 months. So this is something that really tells us how the bronchiectasis vicious cycle is really tough to break. And sometimes patients may still keep getting several exacerbations that have to be noted and treated accordingly. And usually whenever we start antibiotics, we are looking for symptoms such as cough, increased sputum production, change in the nature of the sputum, in the color, the viscosity, the purulence, patient presenting with more wheezing, more breathlessness, sometimes hemoptysis, fever, other systemic symptoms, and so on and so forth. These are the common organisms in acute exacerbation. Sorry for the slightly dull slide, but most commonly we may find non-pseudomonal, we may find Streptococcus pneumoniae, H. influenzae, Moraxilla catarrhalis, and Staph aureus. In fact, I've had a patient who grows one of these almost every few months despite being on antibiotic therapy. So these are very common organisms in our local settings. The recommended first line is always usually amoxicillin with clavulanic acid. The treatment duration should be around 2 weeks. If you treat it suboptimally, there is a chance of more frequent exacerbations, so 14 days. If it doesn't work, then the recommended second line treatment would be doxycycline for 14 days or fluoroquinolone such as ciprofloxacin, which is also an anti-pseudomonal medicine for 14 days, or cephalosporins like ceftriaxone. So usually almost constant recommendation across these organisms. The other group of organism is MRSA. Now, if MRSA is isolated, we have to give therapy which is suited to MRSA infections. The guidelines recommend doxycycline and rifampicin and trimethoprim. However, in a setting such as India, we do not give rifampicin and we restrict it to TB patients. So we would not want to start it in the first go. We could start other oral MRSA preparations, and we could also start the patient on the linezolid, which is a third line in case of MRSA according to the guidelines. So we would prefer that, or vancomycin as and when needed based on patient severity. IV preparations, vancomycin, linezolid is an alternative, 600 BD. When the patient grows coliforms or gram-negatives like Klebsiella and Enterobacter, oral fluoroquinolone or ciprofloxacin is the first line for 14 days, and IV ceftriaxone is an alternate in the dose of 2 gram for 14 days. But for Pseudomonas aeruginosa, things become more complicated. We may try with an oral anti-pseudomonal like ciprofloxacin, and in the dose of 500 milligram twice, or even 750, even up to 750 twice when it's more severe, but 14 days is the take-home message here. And if you want to look out for this, the optional medications or the second line medication, then for monotherapy, we may start with ceftazidime or piperacillin tazobactam or astronam, and we can also go by the sensitivity testing report. Combination therapy can be tried if this doesn't work, along with aminoglycosides, either IV or nebulized, and we'll be talking about this in the coming few sections. So antibiotics, we either start with 14 to 21 days of short course, or 14 days of short course, or 14 days to 21 days, which is called long course. And we may also consider long-term antibiotic therapy if there are more than 3 exacerbations in a year despite treatment, and especially in patients who have had chronic Pseudomonas aeruginosa infection and bronchiectasis, we may have to consider a long-term treatment with an inhaled antibiotic. So what are the guidelines of treating a chronic Pseudomonas aeruginosa in a patient with bronchiectasis? We would first prefer that if it's Pseudomonas, we would give a long-term treatment with inhaled antibiotics against an oral antibiotic. Because when we're dealing with chronic Pseudomonas as a colonizer, as I said, things can become more complicated and persistent. If the inhaled antibiotic is contraindicated, it is not tolerated, it's not feasible, it's expensive, so not possible, then we can give the patient macrolides such as azithromycin or erythromycin. If your patient continues to have too many exacerbations despite taking this inhaled antibiotic, then in addition to or in replacement of the inhaled antibiotic, we can add the macrolide. So that's something that's really important. So what happens when you detect Pseudomonas aeruginosa chronically? If you have a chronic Pseudomonas aeruginosa colonized patient, the guideline recommends using inhaled colistin for these patients. We also consider inhaled aminoglycoside like gentamicin as the second alternative. We consider azithromycin, erythromycin as an alternative if he's not tolerating inhaled antibiotic, as I said, and instead of an alternative, we consider it as an add-on therapy if it's still a high frequency exacerbation. But what is a good clinical practice? To ascertain antimicrobial stewardship here before we start macrolides, before we start long-term antibiotics, to make sure we are not dealing with other infections like non-tubercular mycobacteria. We have to ensure that we have at least some test depicting that there is no NTM, if possible, at least one negative culture for NTM. And if your patient has a hearing loss, a renal issue, we will have to be more careful when we are using aminoglycosides and macrolides as well. So that has to be taken care of. For patients with non-Pseudomonas aeruginosa infection, long-term macrolides, and these may be contraindicated, not tolerated in certain patients, and then you look out for the antibiotic susceptibility. So as you see, the difference here is we are not giving inhaled antibiotics for non-Pseudomonas aeruginosa infections. So again, a beautiful flowchart, more than 3 exacerbations a year. First, you check your physiotherapy. You do the test. Sputum culture shows Pseudomonas. Inhaled antibiotics preferred. Non-Pseudomonas macrolides prefer. Interchangeably adding if it's not responding, and combining the oral inhaled treatment, or we look at long-term targeted oral antibiotic other than macrolide if it's a non-Pseudomonas infection. When you are giving macrolides, make sure we rule out NTM and hearing loss. When you are using inhaled aminoglycosides, make sure you avoid if patient has a renal condition and avoid concomitant nephrotoxic drugs. Talking about inhaled long-term antibiotics, inhaled antibiotics which are long-term have to be considered once you have ruled out that you've taken care of all modifiable factors like airway clearance techniques. And also when we're talking about non-Pseudomonas aeruginosa infection, only if the oral antibiotic prophylaxis is contraindicated or documented ineffective, we would think of long-term inhaled antibiotic. Few considerations about azithromycin. Since it is known to have dose-related adverse effects, you start with a lower dose, say 250 milligram 3 times a week, and then you increase the dose as per response and the adverse effect that the patient has. Further considerations, if your patient has repeated exacerbations, he keeps becoming symptomatic between significant exacerbations, you may start a long-term antibiotic treatment earlier than the deterioration. Sometimes for patients who have very high frequency, say more than 5 exacerbations, the guidelines do mention the role of cyclical IV antibiotics. But they also mention that before you give whether inhaled or IV antibiotics, perform a challenge test. When you're giving an oral prophylactic antibiotic, they ascertain that we must not keep changing the oral antibiotic monthly. There is no monthly rotation that one has to do in terms of the risk of resistance. We must keep the same prophylactic antibiotic and change only if needed after sensitivity tests. Now coming to very important aspect, which is eradication treatment. When we are talking about Pseudomonas aeruginosa, a new isolate in a patient with bronchiectasis COPD, go on and do an eradication protocol. That's very important to protect the patient from repeated infections. But if it is not Pseudomonas, say it's Haemophilus, it's Klebsiella, it's Streptococcus, you do not need to do an eradication protocol and just treat the patient for 2 weeks as mentioned. You offer eradication protocol also to patients who have a new growth of MRSA or who have regrowth of MRSA intermittently. And a good practice would be to keep sending the sputum cultures immediately before you start the antibiotic and at each clinical follow-up after you give antibiotics to know what is the status of eradication in this patient. So, for patients with Pseudomonas, new or infrequent growth as a strategy for eradication, the first line would be ciprofloxacin in the dose of 500 to 750 milligram twice a day for 2 weeks. The second line would be an IV anti-pseudomonal beta-lactam with or without an IV aminoglycoside for 2 weeks. This has to be followed by a nebulized colistin, gentamicin, or tobramycin. The dose of colistin is supposed to be around 1 million units twice a day, ideally delivered through a compatible nebulizer such as the INEB, which is mentioned, certain ultrasonic nebulizers. So it's also very important to consider the type of nebulizer that the patient is using, because that will determine the delivery of the nebulized antibiotic. In patients who keep getting one or more exacerbations of Pseudomonas aeruginosa in a year, there is a very important role of inhaled antibiotics. These are the three possible and alternative eradication protocols based on what is commonly used from the ERJ 2017 guideline. The first is that when you first isolate, you again confirm that this sample has persistent Pseudomonas aeruginosa. As I said, oral fluoroquinolone for 2 weeks, and then IV antibiotics and inhaled antibiotics, the total duration to be around 3 months. Now, the alternate here is you could start with IV antibiotics, which is the beta-lactam plus aminoglycoside for the 2 weeks, and then inhaled antibiotic for 3 months. Now, your patient cannot tolerate IV antibiotics or they are contraindicated. Then you go ahead with oral fluoroquinolone or IV antibiotic plus the inhaled antibiotic. So, you could add a ciprofloxacin 750 mg BD and add inhaled tobramycin or inhaled colistin or inhaled gentamicin to this treatment. The initial phase would be again 2 weeks, and then you continue the inhaled form for a total of 3 months. So these are the three possible pathways for eradication you can take. Again, talking about chronic Pseudomonas aeruginosa colonization, it's important to remember that it is important to treat it because it has more mortality during the follow-ups. These patients have more risk of admissions, more risk of exacerbations, a poorer quality of life, a worse severity on radiology, and a faster lung function decline. If a patient does not have Pseudomonas but some other organism which is chronically colonized, there is more hospital admission, there is more airway inflammation, but at least the mortality risk is not as high as with Pseudomonas. But the more the bacterial load in the sputum, the greater the inflammation, the more the exacerbations and hospitalization. When we are talking about any chronic lung disease, we can never ignore pulmonary rehab. It is recommended that you can offer pulmonary rehab to anyone who is limited functionally with bronchiectasis if their MARC score is more than 1. We can also consider inspiratory muscle training along with the conventional rehab to benefit the patient. And it's important to tell your bronchiectasis patient that they should enroll in an exercise training program. And whenever they come to your clinic, consider doing tests like a 6-minute walk test, a shuttle test, an intermittent shuttle walk test to determine their functional evaluation. Need for chest therapy, physiotherapy cannot be undermined, and it needs to be really inculcated in your patient right from diagnosis. Their frequency and duration of the clearance technique that they have to do will be tailored based on your patient's exacerbation. But in general, the guidelines recommend a minimum of 10 minutes up to 30 minutes of chest physiotherapy every day. After this, they can continue to do these physiotherapy maneuvers until 2 clear huffs or coughs without sputum are completed, or when the patient starts to become fatigued. So a minimum 10 minutes and then 2 clear coughs, and then he can stop it. Up to 30 minutes he can do. There are a lot of chest physiotherapy interventions, and the next video that I intend to make on bronchiectasis is on a paper which has the guidelines for chest airway clearance. But just to quickly summarize the ERJ 2017 flowchart, which says that If the patient has mucus related problem, postural drainage might work. If it's expiratory flow modification to be done, then a slow expiration along with drainage techniques and ACBT, which is very common in the physiotherapy circles, the active cycle of breathing techniques, coughing, huffing, and instruments such as the PEP device and oscillatory PEP device, the PEP mask, flutter, acapella, they can be used along with high frequency chest wall oscillation. I personally would give each of my bronchiectasis patient the choice to have a PEP device with him at home and practice. Exercise intolerance needs aerobic training, strength training, and the patient has to be in the program. And definitely, if he has muscle weakness, then inspiratory muscle training has to be incorporated. So, physiotherapy management we'll be discussing in the coming videos. Regarding long-term mucoactive treatment, some patients who have difficulty in expectorating, they may need mucoactives, but it is recommended that we should not offer human DNAs to adult patients. That's a very, very strong recommendation, that other mucoactive medications can be given, such as ambroxol or mucolytics, they can be offered. Long-term bronchodilators should not be routinely offered, but definitely if your patient has COPD or asthma, he will require it along with the treatment. For bronchiectasis, if patients have significant breathlessness, then bronchodilators can be given, but we do not offer long-term oral corticosteroids except if he has ABPA, asthma, COPD or IBD. We do not routinely offer PDE4 inhibitors, methylxanthines, or even leukotriene receptor antagonists, and we do not offer other medications for anti-inflammatory roles such as neutrophil elastase inhibitors, CXCR antagonist, and statins. So there is no evidence to establish that effect. Airway clearance for exacerbations has to be really pumped up. We will again discuss it during physiotherapy and clearance techniques talk. But we really have to increase the airway clearance frequency from twice to 3 to 4 times in an exacerbation. And we commence the physiotherapy when pulmonary rehab and postural drainage. And we can offer humidification, hypertonic saline, nebulization, manual techniques, and positive pressure devices like the NIV for also airway clearance, or the negative airway clearance techniques during an exacerbation. If the patient deteriorates, we assess for the causes, we assess for the progression, we reassess the pathogens, we reassess the causes and the comorbidities. We optimize the clearance, we optimize the antibiotic therapy, we treat the exacerbation and give oxygen, and then consider if your patient will need LTOT or NIV or surgery. For follow-up, at least an annual evaluation is a must. If he's having more symptoms, it should be more frequent, so tailor according to the patient. Perform pulse oximetry at each visit. We all do that, and that guides the ABG assessment in selected patients. Perform a baseline X-ray if the patient is coming more infrequently at each visit, and also perform sputum cultures more regularly. Some patients with an infective exacerbation may still respond to an antibiotic even though the resistance pattern shows that the antibiotic is resistant, so we can definitely give a trial. We change the antibiotics only if there is no clinical response and keep repeating the sensitivity testing. The routine monitoring tests include the severity score, the BSI, assessing the BMI of the patient, looking at the exacerbation history of a patient, the cultures, the dyspnea scores, spirometry annually or 6 monthly, CT scan at diagnosis definitely, plus minus when needed, sputum mycobacterial culture preferably at baseline, SpO2 monitoring every visit, underlying cause investigations, and comorbidity assessment. Surgery has a role, and it is to be considered if the disease is localized, not controlled, not optimized. The patient needs a good multidisciplinary assessment and, very importantly, a good nutrition pre-op to be the right candidate for surgery. Refer your patient for lung transplant if whether he's aged 65 above or less but has a poor lung function. FEV1 less than 30% is a strict criteria, with significant clinical instability or rapid progression and deterioration. Earlier, the transplant referrals were mostly restricted to patients with massive hemoptysis, severe PH, ICU admissions, or respiratory failures, but they have now enhanced the transplant referral to patients who already have started having clinical instability or progression. That brings me to the end of the first section of this talk. I'm going to give you quick key takeaways from the World Bronchiectasis Conference, the newer developments and the insights which were published in 2023 after the conference. So, according to the Bronchiectasis Conference, it is a globally rising disease. More and more people are getting affected. The most common causes are turning out to be post infective, with SARS, COVID, viral pneumonias, followed by autoimmune, COPD, asthma, TB, which is not the same in the country I work in, but it's not at the back of the list, but rather initial cause, fungal infections, and genetic causes also. There is a new concept of treatable traits coming up, with eosinophilic inflammation getting a lot of attention in bronchiectasis, just like in asthmas. And it's been suggested that in future we may be using blood eosinophils to guide the Th2 inflammation in patients, especially with asthma and bronchiectasis together. Two trials are ongoing. The Willow phase 2 trial in 2020, which is showing a benefit of a new drug called brensocatib for reducing the frequency of bronchiectasis exacerbations, and it decreases the activation of neutrophil serine proteases and peptidases. There's another phase 3 study, the ASPEN study, which evaluates the efficacy of brensocatib. Another phase 2 study and a lot of new studies looking at respiratory microbiome in bronchiectasis and proteinase inhibitors being studied. The conference takeaway includes that IV antibiotics should not be used for mild exacerbations. Inhaled antibiotics should be added to systemic treatment for eradications. And in future, we are going to look at a lot of research into microbiome, biomarkers, and clinical evaluation and drugs for bronchiectasis in biologics. One mention of the EMBARK study, the EMBARK India registry, which followed up patients in India having bronchiectasis as a multi-center study. The main takeaways from the EMBARK India registry was that mortality is independently dependent and associated with increasing age, COPD, cardiovascular disease, more dyspnea, cigarette smoking, frequent exacerbations, and Klebsiella pneumoniae infection in the Indian population. And more frequent exacerbations are seen with COPD patients who are symptomatic and have had Pseudomonas aeruginosa. They had more lung function decline, and Klebsiella pneumoniae has also emerged as a very important pathogen with poor outcomes. Indian patients were found to be more younger, males with more severe bronchiectasis, and the most common cause, as I said, in India was pulmonary TB rather than viral pneumonias. In the next video, we'll be talking about certain takeaways from the ERS 2017 guidelines, and we'll read aloud the ERS statement on airway clearance techniques in patients with adults and bronchiectasis. So keep reading and keep enjoying. See you again with another video. Please like, subscribe, and share my channel, Pulmonology Read Aloud. Thank you and have a nice day.